Glaucoma. So glaucoma is a multifactorial progressive degenerative optic neuropathy, and it is the second most common cause of blindness worldwide. And OCT, it is a non-invasive technique that allows for in vivo cross-sectional imaging of both the retina as well as the optic nerve head, especially in patients with glaucoma. So there were Heidelberg retinal tomography and scanning laser polarimetry that were available that measured the retinal nerve fiber layer thickness in the past. But the OCT measures the thickness of the tissue in toto, which is an actual structural measure. So OCT data is a cross-sectional data and is not interpolated to the future. So OCT can measure multiple structures, including the nerve fiber layer thickness, optic nerve head parameters, and macular thickness. And in doing so, it allows a correlation which helps in better decision making. So different instruments are there in spectral domain OCT, like Cirrus, HD OCT, RT-View, Spectralis HD OCT, 3D OCT 1000, 3D OCT 2000. So the basic differences and why we are mentioning this here is that the different instruments have different scanning protocols. So if we are doing an OCT scan in one machine, we have to compare it with that machine only. So the multiple scans should be done by that machine because all the machines have different scanning protocols. So spectral domain OCT, it provides an objective nature of imaging as against the psychophysical nature of visual field testing. So it is an objective test. So before even a visual field defect has appeared in patients with glaucoma, we can easily assess retinal nerve fiber layer thickness in patients with in the patients of pre-perimetric glaucoma. So this is a Cirrus HD OCT picture in which is divided into different sectors, which we'll be discussing in this presentation. So first sector is the patient information. This patient information is very important. So we have to enter the patient information very carefully because the machine will recognize if we enter the data incorrectly in the follow-up visit, then the machine will recognize that patient as a different one and will not compare that scan with the previous scan. So it is very important to fill all of the patient information very accurately every time. Second is the signal strength. So signal strength is important because if the signal strength is low, the segmentation errors will be more, and it will we will be misinterpreting the OCT scans. So ideally the signal strength should be more than 6/10. This is the topographical map, which is a retinal nerve fiber layer thickness map, which is displayed on the OCT picture. So this is typically an hourglass-like kind of a pattern, displayed in a yellow and a red color around the disc area. And this, in the left side, we can see that this is the retinal nerve fiber layer thickness, which is represented in the form of a color coding in micrometers. We can see that in this below pictures, we can see that because of the increase in the cup area, there is this hourglass pattern has lost, and because of the thinning of the retinal nerve fiber layer. So the cooler colors, the blue represent the thinning, and the hotter colors represent the thickening or the normal values. So we have to identify the artifacts also associated with it because we might misinterpret the report. So different artifacts that have been associated with this. For example, in this picture, we can see that there is a missing data present in the left image on the temporal aspect, and that is misinterpreted as thinning of the retinal nerve fiber layer. So we have to look upon whole of the picture, not only the retinal nerve fiber layer thickness values. And this artifact is because of media opacity. So any vitreous floaters or any vitreous hemorrhage or any cataract, if there is any media opacity, that will not allow the light beam to pass through it, and that will be misinterpreted in the OCT image. Similarly, in this photograph also, we can see that there is a blink effect. So it depends upon the duration of blink. If the blink is of a more duration, then the more of the amount of the data will be lost, and it will be represented as thinning in the OCT picture. And this is a motion artifact in the right eye. So that is also represented as a missing of the black areas on the topographical image. So we should be careful about these artifacts. before labeling the patient as a glaucoma patient. So second thing is a retinal nerve fiber layer deviation map. It is derived from the thickness map, and it is also in this map, the disc and the cup markings are done accurately. So we can see the centration of the disc, which should be present in the center of this circle. The circle is a 3.4 millimeter circle, and disc should be present in the center of the circle. We should be careful about this. And the markings of the disc and the cup are also mentioned in this RNFL deviation map. So the different artifacts are associated with this map also. For example, we can see that in this figure, there is a breakage of the lines. The blood vessels are getting broken in the pathway, and there is a horizontal shift. That is because of the eye has moved, or there is saccades. So because of the motion artifact, this thing can appear, and that will cause a decrease in the retinal nerve fiber layer thickness. So we should be careful about this. Similarly, in this figure, in this artifact, we can see that the disc is now not lying in the center of the circle. So the disc should be present in the center of the circle. Then there are segmentation. We should look upon the landmarks in the segmentation accuracy. For example, this is the horizontal tomograph, this is the vertical tomograph, and this is the circular tomograph. And we can see that this black line, this is a Brooks membrane line. And where it is terminated, that is called a Brooks membrane opening. And this red line is an internal limiting membrane line. So the shortest distance between this Brooks membrane opening and the internal limiting membrane is what is considered as a retinal nerve fiber layer thickness. So the segmentation should be accurate. Sometimes the segmentation is not accurate because of the disease or whether the patient has moved the eye or not. So we have to look upon this segmentation to make the accurate diagnosis. These are the various parameters that are assessed by the OCT machine and are very helpful in patients with glaucoma, like average retinal nerve fiber layer thickness, symmetry, disc area, rim area, average CD ratio, and these are color-coded. Like in less than 1% of these are compared with the normative database. So if it is less than 1%, that is shown in red. From 1 to 5%, that is shown in yellow, and from 5 to 95% in green, and more than 95% in white. And then OCT helps in also checking the ganglion cell layer thickness, which can be decreased even before the retinal nerve fiber layer thickness has decreased. The OCT has a very important value in checking, in monitoring the progression of the glaucoma patient. So there is a protocol which is a glaucoma progression or guided progression analysis in the machine, where 2 baseline OCT scans are needed and 3 consecutive follow-up visits are needed to monitor the change per year. So it monitors the rate of RNFL thinning per year. This is a panomap analysis in which it is an integration of retinal nerve fiber layer thickness, optic nerve height, ganglion cell layer thickness all together. So the OCT is not the only thing that helps in the diagnosis of glaucoma. So there are multiple disadvantages also. So we cannot start the medications based upon the red and green color. That red means go for the treatment, and green means stop the treatment. So because there are many other factors that we need to consider, like myopes and the patients with the longer axial lengths, they inherently have a lesser of retinal nerve fiber layer thin. They have a retinal nerve fiber layer thinning, and that will be projected on the OCT as a thinning. So that is not because of the glaucoma. So we should look upon the other factors also. And there is a floor effect that have been discussed, that in the advanced stages of glaucoma, OCT is not of a great value, because below 40, it will not help in diagnosing and quantifying the retinal nerve fiber layer thickness. So look at the entire readout, not just 1 or 2 numbers. Maintain good quality readings by monitoring the scan signal quality, alignment, and centration of the scan, and watch out for the opacities and segmentation errors. And look for the focal change rather than overall change. It is important and mandatory to use the same machine, same place, and reproducible image quality to ensure a meaningful evaluation and follow-up. Thank you.
Thank you, Dr. Ritika. I hope we have finished.